If people at home have it on their screen.
Yeah, they're seeing exactly what we're seeing right there. Let me just check to make sure. All right, can everybody online here? Okay. Somebody could just type into the message board.
Yeah, I can hear fine.
Yeah, you're good.
All right. Just as a note, in the text box, please, those of you that are online, please type in your name and your EMS number so I can add them place to the roster, please. This is being recorded, so it should be on the recording as well. It's just a way to double check to make sure that we get everybody. Okay. As long as you're ready to go, Doc, I guess we can go ahead and get started.
Sounds good. Well, welcome everybody. Thank you for being here. I really appreciate your time, taking the time out of your busy schedules and meeting tonight together. That's awesome. Tonight I thought our didactic would be on stroke. I know it's a familiar topic. We see it almost every day, and yet it's a stroke, a subject that's a little bit different. There's some subtle changes that are being taken care of, and then in the review, when I do chart review the second hour, we'll go over some mimics of stroke, things that look like stroke that aren't. It turned out to be a little bit different. So if I really wanted to shorten the evening, I could say that people have strokes is the third largest reason for death in the United States. Any questions and leave, but that wouldn't help us in the field very much, would it? So the number one cause of death in the United States is heart disease. That's right, heart attack and stroke. It depends on how you look at it. Stroke is usually it's a cerebral vascular problem, and so the mechanism behind stroke is very, very similar to that of heart disease. And a lot of patients with heart disease have strokes. A lot of patients that have strokes have trouble with their heart. So the American Heart Association does a lot with stroke only for that reason, because they are so inexorably linked. Stumbled over that word one time. So this heart disease is number one. Number two, killer in the United States. Pardon? Yes, that ranks number one actually. No, number two is cancer. All around. Breast and lung are running neck and neck as far as the number one cancers that cause death in the United States. And the third one right behind it is stroke. That's why it's so important for all of us as emergency providers to do the very best we can to get the stroke patient to where they need to be within a very short period of time. So the big thrust of the lecture in the objectives, that would be the next slide, is understanding where stroke comes from. And that way you're more educated, or I'll refresh your education on why people have strokes, what the model is, where those strokes take place, and what symptoms they manifest, because strokes in different areas of the brain have different symptoms. And then what do we do about it? What do we do when we have a patient with a stroke? What do we do in the field? Pretty straightforward most of the time. And what we do for assessment, that's where it's very critical that you guys be critical thinkers, because sometimes your assessment of a stroke patient, or what you think may be a stroke patient, may steer you to come to Haywood or a secondary hospital, or go straight down to a tertiary center. So I'll start with a case, if you guys don't mind. This was one of mine from, I don't know when to put these slides together. I think this was the first time one of the first cases I had here at Haywood. Anyway, a 72-year-old, forgive me for reading this because I can't remember all the details. 72-year-old presents to the emergency room. He's got that speech problem, left-sided weakness. His wife noticed this about 1 hour ago before he arrives in the emergency room. So I'll stop right there. Are we in a good window? Yeah, all right. Yeah, you guys know the window. We'll review that anyway. I'm going to pretend everybody in the room, including me, don't know anything. So if I sound simple at times, it's because I want everybody to see it. So she thought it would go away. How familiar is that story? I thought it would get better. One of the most common problems that patients have that don't get stroke care in the proper time frame is because they themselves don't activate 911. They just wait. All of us are in that boat. All of us get wounds or get sick and we think, well, it'll just go away. My headache will just go away. You know, it's the worst headache I've ever had, and it came on all of a sudden, but it'll get better. So you see where I'm coming from. Does this gentleman have any risk factors besides his age? Indeed, yeah, he's got hypertension, he's a diabetic, and he's got coronary disease. I usually call that the trifecta. It's usually those three are just an automatic given that the patient will be ill. He's on medications that would indicate he is being treated for these for a while. As you already know from your experiences, often you can look at a med list and you know what the diseases are, right? Yeah, so if you see lisinopril or atorvastatin or metformin, you already know in your mind what problems they have, and that's very helpful. Is the gentleman hypertensive? Yeah, for sure. So that's a risk factor. We'll talk about blood pressure monitoring in a little bit. His heart rate's okay. I don't say on there whether it's regular or irregular. That can have a play in how well this guy is going to do. He's a slightly tachypneic, depends on what degree. Is he good and saturated on room air? Does he need oxygen? No. We used to do, and this isn't too terrible long ago, we used to put all our stroke patients on oxygen automatic. We just don't do that anymore because too much oxygen can be a bad thing, right? So next slide. So anyway, this guy went on to have, he had left-sided symptoms. He had right-sided stroke. I believe it was a middle cerebral artery stroke. Unfortunately, he was in the window. We did give him TPA at the time, and he did recover pretty well. Down the road, if I remember right, it's he had a little bit of speech difficulty, but outside of that, big fun. What is stroke? Stroke is a cerebral vascular accident. That's a CVA. That's a term that we still use today. CVAs can happen either because the patient has a sudden embolism that flies up from the circulation somewhere, usually from the heart or the carotid circulation, gets lodged in one of the arteries in the head and causes a stroke. That's an embolic stroke. Or the patient has a thrombotic stroke. Thrombus is a developing clot in the existing artery over time. So that's the only difference. Eventually, the thrombus decreases the blood flow to wherever it's going, and wham bang, they get a stroke. Okay? Strokes are usually sudden events. Okay? Not this intermittent phenomenon. Usually, this is more of a pre-stroke phenomena, or what we call a TIA. So the symptoms can come on, but then they eventually get better. Or the patient or the family member will tell you, oh, I've been stumbling for the last couple of days, or I've been tripping over my words. Now, I have speech trouble in the morning because I don't have my coffee. So once I have caffeine, I'm all set to go. So it's just a silly example of what other things to think about. So why do we use that word? Where did that come from? Just as a way of interest, back in Greek days, when the Greek physicians were first putting a lot down in written form to give us medicine as we know it today and understanding, they described these sudden events as a stroke of bad luck. That's how it got its name, believe it or not. So it is a stroke of bad luck for these people, and that's why we still use the term today. Next slide. I'm sorry you guys can't see all this, but just the big ones. This is the brain circulation, and at the end of the lecture, you guys are going to be quizzed on this. I'll pass out a diagram. Just kidding. Three big arteries you got to know, and we're going to discuss this. Why? Because the symptoms are a little bit different in what you see in the field. When you come up from the carotids up underneath, you come here. This is the circle of Willis, this little thing here. Okay? And we have the interior circulation, which goes out to the cortices and the left and right frontal lobes. This helps us think and reason in real time. And then we have the middle cerebral artery, which is right here. Okay? And that's a big one too. The middle cerebral, the MCAs are pretty big diameter. They go up and feed the temporal lobes largely. And there's feeders off into the deeper parts of the brain. And then you have the posterior artery with cerebral artery. So the ACA, the MCA, and the PCA. Those are the big three we worry about. Now, when you guys read MR reports and you see reports from interventional radiology, after they've freed the clot, you're going to see MCA1, MCA1A. These are just branches off there. And that's far above and beyond even my understanding. That's all neurosurgery and all that stuff. But that's all these little branches that come off and feed specific parts of the brain. So these are the big three, and they come off largely fed by the carotid arteries, which feed 80% of your brain. The other 20% of your brain are fed by the vertebral arteries, which come up through the spinal cord, and that's these little boulders right back here. And they come up through the posterior circulation. And there are posterior strokes that are very, very serious. We'll go over signs and symptoms in just a bit. Okay? Thanks, Tom. So let's look at anterior cerebral. So the anterior cerebral artery is suffocating. It's not getting blood flow to the front part of the brain, either because of an embolism, a blood clot that broke off because the patients have AFib. As a side note, why does AFib cause stroke? Why do AFibers get clots? Does anybody know? Yep, the irregular heartbeat is always irregular. So the atria are flapping and they're not contracting, getting all the blood out of there. So when blood pools, what does it like to do? It clots, right? And a piece of that clot will break off. There is an appendage on the left atria. It's a left atrial appendage. I think that's kind of a good name for it, since it's an appendage. It is just a little bit of a area in the left atria that doesn't get much blood in it. But when you have atrial fibrillation, that appendage fills with blood and it just sits in there. And guess what? That's where a lot of those clots, emboli, come from. So in your workings from day to day and in your reading, you'll see that there's a procedure on these patients called a Watchman procedure, which is a procedure to open that up and to disallow blood to pool in there, and thereby decreasing the risk of blood clots to the brain. So just a side note. That's why AFib patients need anticoagulation, because they're at high risk of throwing clot from the atria, largely the left atria. So that being said, these are your symptoms. You don't see them over here. Get a better camera. So hemiparesis, that involves the leg more than the arm and the face. And this we don't see very often, right? You know, so if the patient is saying my left leg or my right leg is weak, but I'm moving my arms, I don't have arm drift, my face is fine, start thinking anterior. They're incontinent of urine very largely, and they lose some reflexes, and they're very, very slow to respond to you. Because the frontal area is your now and think part of your brain. So if your now and think part of your brain isn't getting the oxygen flow, it's not going to think right. Okay, so that's kind of a good way to remember it. I wish I would have put it on my slides. I thought of it coming over here. So that's how bad I am. But there's a diagram that looks really weird. It's called a homunculus. And it's a diagram on the brain. There's this cartoon of where everything is, like the leg and the foot and the arm. I don't know if you've ever seen a drawing of it, but it's the foot and stuff lays over the front of the part of the brain, and the arm is back here. It's really weird looking. That's just a diagram to tell you where everything is fed. Let's go to the next one, Tom. This is the middle cerebral artery syndrome. The most common, this is the classic stroke that we see a lot of. This is the sudden-sided hemiparesis, facial paralysis, that speech problem that the patients will have. The aphasia generally locates itself to the dominant hemisphere. These patients can be inattentive. What does that mean? When they're looking at you, they're really not altogether there. Kind of like your children when you said, "What did you do? Did you make your bed?" They're kind of looking at you like, "Did you steal that piece of candy?" No. It's like, so that inattentiveness. And another inattentiveness is when the patient can't see to their left or to their right, or you have them turn their head and they're still looking to their left. You know what I mean? Have everybody seen that in the field? They're not all together there. They're inattentive. Or they can't tell you what is numb. You know, they can't tell you what limb is involved. Or you ask them a command, raise your right arm, and they just look at you. And they can't understand. Raise your right arm, and they'll stick their leg out. They just, so there's a disconnect in the brain there. Next slide, Tom. Thanks. The posterior cerebral artery syndrome is a little bit less common, and it affects balance and coordination largely. That'd be the next slide, Tom. This is only about 20% of your strokes. These patients have a visual loss very typically. So it's like putting a window shade vertically over your eye like this or horizontally. They can't see one portion of their vision. So if the patient's saying, I've got visual problems, when you bring your finger over here and have them look straight ahead, they can't see their finger. Everybody can do it. If you're looking straight ahead, you can start seeing your fingers off to the side. Eye doctors do that all the time. But your visual field changes. These patients are unaware of this until they're tested sometimes. They don't realize they've got that visual loss. And they lose sensation. They feel tingly. They'll say tingly, prickly, numb, using words like that. And often there's no disruption of their speech and their ability to think and to reason because the stroke is back here. The thinking and your speech function is more front. The speech area of the brain is to the left. That's Broca's speech area. It's right here on the left side, left hemisphere. So if this is not affected, the patients can talk and they can speak, they can reason, they can remember when they started feeling poorly that they're really weird. Another thing in posterior strokes too is they're very stumbly and uncoordinated. So if you have them do a heel to shin, they're not going to be able to bring their heel to the shin or finger to nose testing. They're going to go like this, or they're going to be very slow to do it or miss their nose entirely. Okay, next slide, Tom. The vertebral-basilar syndrome is that of the vertebral-basilar arteries being clogged off. We don't see that very, very often, and sometimes it's due to a stroke or an injury to the cord. So this could be a transection to the neck. This could be a tumor, lysis, and so forth. These patients are very uncoordinated. They have vertigo, something terrible. Usually that's the first symptom. They also can develop Horner syndrome, and Horner's is easy to see. They have one lid that's drooped, so they have ptosis of the eyelid. The pupils are not equal. The affected eye will be dilated, the eye drooping. So if you see a droopy eyelid and a dilated pupil, that's probably Horner syndrome. It could indicate a posterior vertebral-basilar stroke. Anybody anatomically know why? Give you a bonus point. What's back there that would control your eyes?
The occipital lobe.
Pardon?
The occipital lobe.
Yeah, that's right. In the occipital lobe, there's the optic chiasm. That's where the optic nerve begins. It's right back here. And then when it comes forward, it crosses over in the midbrain and becomes crossed over. So the right controls the left eye, the left controls the right eye. And we're all twisted in the head, me included. So this is an interesting thing if you guys see Horner's, just fun stuff. Another thing too is these patients are often dysphasic. They have trouble swallowing. So if you ask them about that, if you remember, they'll tell you maybe they're gagging or choking, or they'll have a sense that they are. That's why in the ER we often do, we'll put the patient's NPO and then we'll do a swallowing test. Use just a little water and see if they can swallow or not. It's just an often sign of posterior. Now, Dan, do posterior strokes and vertebral-basilar strokes kind of present in the same way? Yes, because both of those circulations can affect the back of the head, on the back of the brain. So they can present similarly. All right, Tom, next one. So we have those syndromes. The anterior cerebral artery, the middle cerebral artery, which is the one you're going to see the most, and then the posterior cerebral artery, and then the vertebral-basilar and vertebral arteries. Okay. Now, do I treat these stroke patients differently because they have different symptoms? Nope. All bets are off. We treat them all the same because it's the same mechanism, right? It's a blood clot, or it's a thrombus. So they all get treated the same. It's just good as clinicians to understand what you're seeing and what kind of a stroke it could be, and it'll help you with your differential, okay? These patients will typically have sudden everything, sudden loss of speech, sudden numbness, sudden weakness, sudden change in their speech, sudden confusion. It comes on not over 6 weeks, not over 2 weeks. Miss Mary has been ill with a fever for the past 3 days, and she's a little bit slurred on her speech, a little bit confused. And by the way, she's got a temperature of 102. So that's gradual, and you're thinking clearly stroke could be behind this. She's 72 and has risk factors, but it came on kind of gradually. Unlike if you get response to the same for sudden altered mental status. What time did this start? Oh, just a half an hour ago. She was fine, and all of a sudden she's babbling. Can't say her words right, or she's saying stupid stuff. I ask her, what time is it? Oh, I took the dog out yesterday. I mean, the response just doesn't make sense. Came on all of a sudden. Stroke is often sudden in onset. Next time. Sorry, making my Now here's a syndrome that's really weird. It's called lacunar syndrome. Have any of you heard doctors or providers say the word lacunar stroke before? What is lacunar? Lacunes are areas in the midbrain down around, if you open up my skull, please don't do this live. My wife will hate you. Great. Take the skull off, take the frontal and the temporal lobe out of the brain, and down in the midbrain is an area called the thalamus, and that's right around and above the pituitary glands in the hypothalamus. And that's where our emotions are, and that's where our reasoning is. The lacunes are fed by very tiny blood vessels. And usually lacunar infarcts are infarcts that happen in patients with, you guess it, hypertension, hyperlipidemia, and diabetes. Because those diseases and other ones we'll care not to mention cause inflammation and irritation inside those little arteries. And as a result, artery doesn't feed the oxygen to the area. And guess what? No oxygen, no function. Nerve cell says, I'm out of here. Because I'm not getting oxygen. Remember, the brain needs two things to survive. What two foods does the oxygen need?
Oxygen.
Glucose and oxygen. That's right. And without the two, either one, the patients get really squirrely. That's why we always check a blood glucose at a stroke or altered mental or whatever it may be, right? Because hypoglycemia can be stroke. Jumping ahead of myself. But these are kind of unusual, but we do see them in about 30% of the patients, oftentimes. And these symptoms are very, very specific. My right hand is numb, or my left upper arm and shoulder don't feel right, and I can't move it very well. You can imagine how frustrating it is for all of us. How many things can make your arm not move very well? Could that be a labral tear? Could that be rotator cuff? Could that be osteoarthritis? Could that be pinched nerve off the neck? Could it be a lacunar stroke? Keep going. Yeah, differential's big. Okay, next slide. Oh, and if I ramble too much, you guys just scream at me, spit, throw a tomato. Okay? Pure motor stroke is all that. It's just motor. I can't move my right arm. I can only adduct it here. I can't move at all. And pure sensory, that makes sense. That is where they have complete numbness in one specific area. My hand's numb. My foot's numb. I've got some numbness on the right side of my face and my neck. It's just very focal. Can you differentiate in the field whether it's a lacunar infarct or not? Highly doubt it unless you're super sharp and have a CT scanner in the truck. But it's even hard for us. And a lot of times we don't know if these patients have a lacunar infarct until we actually image them. With a CT or an MR. MRs are obviously the golden standard. Okay, so thanks. Here's another syndrome of the lacunar patient. They have a real clumsy hand. So, Mary, could you reach out and grab my pencil or pen, whatever you have, and they'll go like this. They just can't grab or can't pick it up. They're very clumsy. Or they grab something and it just immediately drops out of their hand. They have no grip strength. They're clumsy with their foot. They have foot drop, and foot drop again can be a sign of symptom of a lot of other things too. So it's weird stuff. Their face may be weird. So these patients will actually do well. Their prognosis is really quite well. What we do is we put them on antiplatelet therapy, aspirin and or Plavix for a good 21 days. So aspirin for a good 6 months to a lifetime, and usually try to control their blood pressure, diabetes, or whatever is behind it. All right, next slide. That's the period part. This is a review because I mentioned it earlier. Strokes are either ischemic, that means that something's going on to decrease oxygen flow to that area. They're having the big one. MIs, do MI patients circulate very well? Do they perfuse very well? Absolutely not. How about a patient that's bleeding out from a pelvic fracture? Nope. How about a patient that is septic? Are they perfusing very well? Right? So that's all examples of shock. And distributive shock, septic shock, obstructive shock from a PE, whatever it is, those patients don't do well, and they can go on to stroke. So you can have two things going on at the same time. So you might be called to an altered mental status when you get there. That patient may be stroking, but they also have a fever of 103, and pneumonia, and the pressure is only 70. So what do you treat first? You obviously treat the hypotension first, right? They're shocked, so shock first, and then go from there. Okay? Or hemorrhagic, that means they're bleeding in the head. Uncle Remus decides he's 83, he's got AFib chronically, and he's on Eliquis. And guess what? Doesn't he fall going into the senior center? So you get called for man bumped his head. So grandpa fall down, go boom. And of course he's on an anticoagulant. How many of our patients are not on anticoagulant? Possibly. They seem to be like candy nowadays. So anyway, guess what? The first is on your differential. You guys know this just as well as I do. You're thinking brain bleed, aren't you? Because you get to the scene, this guy's starting to talk funny. He's dysarthric. He's numb on one side. He's confused. And you find out from his wife who's with him, oh yeah, he's been on Eliquis for about a year. Okay? So that's a hemorrhagic stroke. So largely, strokes fall into those two big categories. Granted, there is other reasons for stroke, like we just talked about, lacunar infarcts from hypertension. Next slide. So I'm sorry, this is small. I'll run it down for you. Ischemic means, or if it's thrombotic, that's a thrombus. Over time, blood has gotten thicker and thicker in the wall of the vessel to the point where the vessel is not delivering its blood supply. It's kind of like you going out and the kids are having fun on the water slide, the slip and slide, and just as a joke, you start pressing down with your foot on the garden hose. Pretty soon the water stops, the slide dries up, and the kids can't go down anymore, and they wonder what happened. It's kind of a sort of pseudo good analogy of what happens with blood clots. Clot formation and plaque rupture is the number one etiology or pathophysiology of why this happens. This is why we put patients on antiplatelet therapy. This is why they're on aspirin and Plavix, because the aspirin and Plavix interferes with the clotting process and allows the blood to continue to flow. Here's another etiology. These patients are particular. There are a few sicklers in our community that have sickle cell, and if they do, they're much more prone to stroke, as well as infarcts in solid organs like liver, kidney, heart, and bone, maybe a bone infarcts. So they sludge. Their blood flow is really poor. Sicklers is because their hemoglobin is defective, so the red cell is shaped like a sickle. That's how they got its name. Other patients with polycythemia vera, too many red cells, that leads to a lot of congestion, doesn't it? It's kind of like going into Boston during rush hour. That's what polycythemia is. Protein C deficiency are patients that clot really easy. This is I've had DVTs 3 times, I've had PE twice, and they're on anticoagulants and antiplatelets just because of that reason. Thirdly, last but not least, is just plain old artery damage. The artery is inflamed, that's called arteritis, or they're undergoing an aortic dissection, and you can imagine the turbulent blood flow when they're dissecting the aorta. Guess what happens up here? So they're crushing chest pain, but they could stroke, if you want to stroke sometime. Thanks. Now let's look at the embolic side of things. I hope you don't mind if, can everybody see that I'm reading down through these because I don't know if they're coming across right. This we know about. We see this all the time. These AFibers with the neural thrombus, like I told you about, where the atria are dilated. How about the false valve, the artificial valve patient? Who strokes more? Is it a little quiz? Is it mechanical valve patients or natural valve patients? Pig valve, cow valve. Mechanical, right? Mechanical, because the metal tends to tear the red blood cells as they come across the valve mechanism. That's why mechanical valve patients are often anticoagulated. Not all bovine or porcine valve patients are anticoagulated, just for that reason. What valve lasts longer though? The mechanicals, yeah. The St. Jude valve was the very first one invented, and I believe that was invented in Massachusetts, if I'm not mistaken. Aortic sclerotic plaque is the big one. That's up in the carotids mostly. That's a very, very common etiology for stroke too. That's why on stroke patients, when they're admitted, part of the workup is doing a Doppler flow study of the carotids. 80% of our brain is fed by the carotid arteries. So we do this, we do an MRI, and what other organ do we look at? The heart, right? We do an echocardiogram. The reason for that is to look at the atria, look at the ventricles, look at the valves. Are they contributing to the patient's stroke because they're really bad on? Okay? So there you go. That's an embolic stroke. Yeah, next slide. So what about the weird ones? The case I gave you earlier as a patient that has 103 temp, respiratory rate of 36. Yes.
Sorry, I just didn't want to interrupt you. Is there
No.
Jacob in the class? Jacob something. Can I say?
Okay.
Perfect. Can I talk to him about it? Do you have a Subaru?
Yes, I do.
Yeah, it's gonna hit your car.
Uh-oh.
Sorry. Sorry. dude.
Don't give them a ticket, just a warning.
That sucks.
So sorry, yeah, that's too bad. So these are the patients we gotta watch out for, guys, because, and ladies, because there is a risk of these patients going on to stroke because they're so sick. These are the hemorrhagic patients, the patients in distributive shock, obstructive shock, whatever it may be from the patients that are bleeding. Even a straightforward UTI can turn into a pyelonephritis, which can turn into a stroke. They deteriorate. And obviously, the older the patient, the more risk factors they have, the more dangerous it is. And Dan, why are you telling me all this? Because my job is just to get them stabilized in the hospital. Yes, but your job is to be a thinking clinician, not just a tech, right? Yeah, I want you guys to be thinkers. Okay, next slide.
Quick question, where would
Yes.
DIC fall under that?
DIC would fall in hemorrhage because DIC patients often hemorrhage, but they can clot. That's a very good question. And on a quiz, if you had a choice of DIC patients, A, clot, B, hemorrhage, or C, all of the above, you check C, all of the above. Because some patients will clot extra big, some will bleed out. And technically it would fall under that. So what are the risk factors? You guys know this. It's hypertension, cigarettes right in the middle. I put that only because I couldn't find in my PowerPoint thing, 5-pointed thing. This is peripheral vascular disease, coronary artery disease, and diabetes. Who's at more risk? A diabetic with type 1 or a diabetic with type 2? Good question. Yeah, type 2 is a little bit more because type 2s are typically older than type 1s. Type 1s have been diabetic since, 9 years old, 11 years old, or whatever. So they're a little less at risk. The type 2s develop diabetes over adulthood, often because of other underlying diseases, obesity, polycystic ovarian disease, hypertension, etc. Thanks, Tom. Next slide. Now, what are the other risk factors? Some of them I've already mentioned. Some of these diseases, deficiencies in protein, PCV, contraceptives. Don't forget, even if it's an under the skin contraceptive, an IUD or a pill, these patients are getting hormone therapy, and those hormones make them a little bit more prone to thrombosis. So these patients can be, clot worthy. Left ventricular hypertrophy, big one there. Why? Because the ventricle is so thick and it gets lazy, so it doesn't pump as well. And if blood isn't flowing, blood will clot, right? So it typically will lead to some trouble. Also, LVH patients are a little bit more prone to dysrhythmias. Okay, so keep that in mind. Atrial fibrillation, we all know that's a risk factor. And what about the MI patient? If you're STEMI or non-STEMI, both are at risk for stroke because the same mechanism that gave them a heart attack can be going on upstairs as well. Okay? Next slide. Signs and symptoms, we already know about this. The big thing to watch out for is anything neurologic that's weird to you. So I like to use the term neurologic weirdness. That summarizes it down to just a quick, because if you're like I am, when you're going to a call, you've got to think like this, right? Think on your feet. So the last thing you want to do is to think of a laundry list of all kinds of things. You want to think, in systems. Is it neurologic? Is it cardiogenic? Is it abdominal? Is it limb? We go through and think body parts and body areas. That's the way I think. So if there's something neurologically weird about this patient, they're confused, they're tingly, they're numb, they're weak, their speech is off, they're confused, start thinking, is this a stroke or not? Okay, next slide. Signs and symptoms we've already touched on. Oh, I wanted to mention this too. Often you guys will tell me on the radio, this patient they're Shane Stoking, or they're demonstrating some apnea. So if there is weird respirations or their ventilation is off, it could be a stroke. Obviously, it's not the number one problem with ventilation, right? Probably the number one is cardiogenic, right? So cardiopulmonary, number one problem with ventilation, but it could be a stroke. So start thinking that too. But anyhow, a lot of these, you see these signs and symptoms, a lot of them are neurologic in origin, speech, movement, sensation, motor, whatnot. Mood, headache. Can headache necessarily cause a stroke all the time? No. But is headache something that we need to be aware of? Yeah, because headache could be an intracerebral hemorrhage. Headache could be a migraine. Headache could be just a made-up excuse to get to the hospital. Headache could be a stress headache because we've got an exam up and coming. Everybody in this room probably had a headache before you took your registry exam, right? Yeah. So next slide. Now, this is tricky, and the reason for this is a big reason, because as healthcare providers, we need to think outside the box. Everything that sounds like and smells like stroke is not necessarily stroke, right? Came on all of a sudden and was associated with some slurred speech and a little bit of numbness of the face. And could it be a migraine? Yep. Can migraines come on rather suddenly? Yep. Even though typically they don't, but they can. Can a tension headache do that? Yes. Can a cluster headache do that? Yep. Can temporal arteritis, which is inflammation of the temporal artery, can that come on pretty quick? Yep. And that's usually associated with visual change on the same side. So start thinking that outside the box. What about cancer? Can cancers give a stroke? Oh, absolutely. Can there be a glioblastoma on the brain that is suddenly causing so much edema around it that it causes the patient stroke? Yep. That's another reason we do CAT scans right away. We've already touched on the fever patient and the infection. Peripheral neuropathy, that can sometimes fool patients as well as providers. Their leg goes numb. Well, how long has it been going on? Well, it just got worse today, but come on, how long has it been going on? Well, it's been on and off for 2 months. Okay, that's probably a stroke, right? But if they just noticed it now, it could be peripheral neuropathy, it could be a stroke. Why would it come on all of a sudden? Just yesterday, I was putting in a rock wall, and I decided to do it alone, and I'm lifting those rocks up and doing the cementing and everything else. And my back is kind of sore. I go to bed and I wake up and my entire right leg is numb and it's weak. Could that be a stroke? Probably not. Could it be a herniated disc? Very likely. Yeah. Thankfully, I did rock wall work, but I didn't hurt my back. Yeah. I put up a closet shelf this weekend. I'm really proud of myself. I found the studs and everything. Air embolism. We don't see it very often, but you guys may think if you go to a patient's home and they've recently had hyperbaric oxygen therapy and they have stroke-like symptoms, think air embolism. Also, chest pain or shortness of breath of sudden onset can be an air embolism from hyperbaric therapy. Just something to think about. Or I recently returned from the Caribbean on a cruise and I was scuba diving. Air embolism, perchance, that's possible. Can you get an air embolism just by flying an airplane? You bet you can. So if you just flew back into Logan, you were on an overseas flight from Tahiti, poor you flying from Tahiti to Boston. I'd rather go the other way. But you can get an air embolism, just something to think about. So this is on the slides just for you. You guys can always Google this too, differential force stroke. And I'm sure in the EMS literature it's written well. Okay. Be aware that you're going to have trouble getting a history sometimes. Amen. How many of us in this room have never ever had trouble getting a history out of the patient? Now, one hand goes up, right? I hate it. It's frustrating. You go in there and they refuse to talk. Number two, they can't talk. Number three, they don't have the memory to do so. Number four, they're demented. They've got some language disabilities. They speak Haitian Creole and you speak English. You can think of a myriad of opportunities your patients can't give you a history. What about that caregiver in the group home that's supposed to know this patient and they're fumbling through the notebook? When was her last meal? I don't know. I just got on duty. So history taking is really difficult. So be aware that communicating after stroke is going to be difficult either because it was before or now they are dysarthric or they just can't find the right word. Okay? My wife accuses me of having strokes. I had husband strokes pretty often. I'm not listening. I can't communicate very well. I won't ask you guys to raise your hand if you guys have husband strokes. We have them sometimes. No antiplatelet therapy in the world is going to help you with a husband stroke. I just say yes, dear. So very important. This is very important. We're going to touch on that time window of 4.5 hours. Always, but always, and in the reviews of the run sheets, I see you guys checking blood sugars. I applaud you for that. That's very good. If the sugar's low, do they have a stroke? At that moment in time, maybe not. If you give them the dextrose and they take the sugar off and it goes to 185 and they're still with stroke-like symptoms, all bets are off that was just a hypoglycemic episode. However, if they went from 36 to 181, and now they're talking and with it, and feeling good, thank you, I think I'll sign off and eat a hamburger. That's probably not a stroke. Probably should go to the hospital just in case, but that's up to you and med control if the patient wants to sign off. All right, thanks. So here's what we do. You guys know this like the back of your hand. And like I told you at the beginning, I may be sounding stupid and simple to start from ground up because you are well-trained professionals, but nonetheless, it's good review. That's why we're here. Always ABCs, always. Every run you do in your professional career should always be, right? Airway, breathing, circulation, disability, environment, exposure, all that, all those ABCs you learn. Okay? The most important thing a patient can do is breathe, right? So if you jump in and you're more worried about their open femur fracture than their airway, you got a little bit of a problem there. Now, can you treat both at the same time? Hopefully. Yeah, put your hand on the bleeding femur and make sure the airway's straight. Or just ignore the bleeding. I didn't see that. All right, airway, breathing, circulation, oxygen. If the patient is less than 94% saturation, make sure you get a good breath with it. Sometimes readings can be inaccurate. You guys know that? When the nurses and I sometimes banter about that, the nurses will automatically put the patient on O2, and they came in at 98, and now I'm super oxygenated patient. They don't need to be at 100%. Okay, and actually we do more harm than good. Where is all this oxygen going to go if the artery is not delivering it? Right? It's going to back up, and it's going to overexpose all the cells behind the blockage to an oxygen-rich environment. The cells don't know what to do with all that extra. It'd be like having your freezer full of roast beef steak, or let's put filet mignon in there. You've got a chest freezer full of filet mignon. It's going to take you a long time to eat through that, right? Same way with yourself. Well, with rare exception. Yeah, me, myself, and I could eat two of those at one sitting. But yeah, keep in mind, you guys, it used to be, and we were all taught this, if you've been in medicine long enough, that we were supposed to slap oxygen on these patients all the time. Yeah. But we just don't do that. Okay, cardiac monitor, obviously that's, and anybody that doesn't put a heart monitor on their patient, probably needs remediation. You guys know this very well. You can't always start an IV, but you can start an IO. Really good to do. If in the field you can't establish IO or IV, all you have to do, and you guys do this well, in your summary, make sure you dictate, I could not start because I was not allowed to start because. Maybe you had a religious preference. Maybe the patient's panic stricken. Maybe they're too sweaty. Maybe something was far more important at the time. You tell me, and when we read it, we'll discuss it. This goes without saying. Can cardiac dysrhythmias cause stroke? Absolutely. Number one, yes. So if a patient is bradycardic at 38, if they're tachycardic at 210, regardless of what it is, if they're complete heart block or not, the patient's control an embolism or blood clot. Very good. We know this for a good fact. A piece of history you must know is last time known well. And I'll tell you why in just a bit. I know you're sitting on your seat. Right? When is the last time you saw your grandfather himself? Sometimes they don't know, right? Just put unknown. Sometimes it's right when he went to bed. What time was that? Oh, about 10:30. Turned in. Well, now it's 8:30 in the morning. It's weird you got the call. So who knows? Did it happen overnight and you were asleep? That's okay because we can still do something within a 24-hour period, maybe. Okay? So that's okay. You just tell me as best you can when the last time known was. Okay? And you do your stroke assessment. We'll jump into that next slide. And you call the hospital and you say, stroke or stroke alert. That's right. That goes with, I wrote it down, that's 2.18 in the protocols. 2024 protocols. Nice job. These are the three big ones that we use. Our region, we don't use the LA pre-hospital screen much anymore. Actually, interesting story behind this. This was developed in Los Angeles. No bring it there. But it was largely not quite as good as the Cincinnati score in retrospective studies. So it kind of lost its favor. That's why you don't see it as often. The American Heart Association publishes a little book. It's called ECC. What's it stand for? Emergency Cardiac Care. ECC, Emergency Cardiac Care. It's a little spiral-bound book. It's A to Z on doing CPR, BLS, ACLS, PLS. It's a nice little book. The American Heart Association has it. But that's what they have in the book. I think that's the next slide. Yeah. So this is a positive facial droop here on his right side, or the left side, I should say. The Cincinnati does face, and you guys all know that face is part of that FAST ED assessment that you do. Is there facial asymmetry? Yes or no? If yes, that's positive. A is for what? What? Yep, arm drip. Yeah, so your patients close their eyes, hold their arms out like they're praying, and you see an arm drip down. That's a positive drip sign. Okay. I had one patient do that, and he went like this. So, oh, you don't have a stroke. He put his thumbs up. I'm okay, doc. Okay, so face, arms, S is speech, yeah. Are they dysarthric? So you ask them to repeat a phrase. You can't teach an old dog new tricks. So they say, it can't, so they can't say the word very clearly. Or they have expressive aphasia. You can't teach an old dog new tricks. They can't get it out. Or you tell them that phrase again, and they say, yeah, I went yesterday. This totally does not make any sense at all. That's receptive aphasia. That's where they heard you, but their brain cannot interpret what you're asking them to do. Or you ask them a simple command in the field, move your right foot, and they'll stick their left arm out. That's receptive aphasia. They just don't understand it. They're totally confused. Okay. So hopefully when they do that, they won't slap you in the face. Right? So we have face, we have arms, we have speech, and then T is your time, last time known well. And then we have E. Yep, that's your eyes. Follow my eyes with your finger. We go up, we go up, we go down, we go left, we go right, and then into the nose, you go cross-eyed. All right, that's normal eye movement. If the eye movement is abnormal, or if you come so far and they're still staring straight, but you go left and they're able to follow you, they have inattentiveness in their eyes. So that's good to know in your documentation as well. Okay. Yeah, this just a reiteration. Okay. Now, what else do I need to ask the patient? Do you have a seizure history, and ask the loved one or the friend or their caregiver, did they have any seizure-like activity when they went weird? This came on all of a sudden. What else comes on all of a sudden? A seizure, right? So, do all seizures shake and bake? No, you can have a seizure just like that, absent seizure, or you can have a focal seizure. We just twitching in the arm. My wife, if she were watching this, Lori would say, "You're an actor." It's just devastating. So keep that in mind. Seizures, especially in a post-ictal state, can mimic stroke. So let's say Johnny come frequently in the group home has another one of his seizures, but this time caregivers are really concerned. They call 911 because he's been compliant with his meds. Everything's going smoothly, but his post-ictal period is really strange. He's much more confused than usual, and his speech is over. Now, that could be what we call TOS paralysis, where they're paralyzed on one side, they're dysarthric, they're having speech difficulty because they've had a seizure, and the seizure has left them anoxic to a particular area of the brain. Lack of oxygen, stroke, right? Same mechanism. Okay? Febrile illness, where they're feverish. If they've been with a fever in the last couple of days, that they have fluid loss, that they have diarrhea. So when you guys go to ultramental status or possible stroke, those are other history questions to ask. Just do your usual assessment like you usually do. Go by systems, nausea, vomiting, diarrhea, any trouble breathing, coughing, fever, any unusual pain, new pain. Have you had trauma recently? Have you been exposed to anybody that has been ill? So, okay, next slide. These are just some more items on the lack of time. I won't touch on. These are more things that I collect in the emergency department. I don't expect you guys to do chest X-ray on the back of the truck, or monitor their chemistry, their blood sugar, or their kidney function, but you can someday. Okay, next slide. So what are our time goals here, you guys? Within 10 minutes of arrival time to my department after you call a code stroke, in theory, doesn't always happen, I'm supposed to have everybody ready. So we typically do. They're supposed to go from ambulance cart to CT within 10 minutes. As you guys have observed from time to time, it doesn't always happen. We're trying to tighten up that loop because within 10 minutes, it's been shown the faster we move within the first 60 minutes of arrival time, the better the outcomes. CT, door to CT, 10 minutes. CT to interpretation by radiologist, 20 to 25 minutes. Interpretation to neurologist, 25 to 40 minutes. Time to needle is 0 to 60. So door to needle, that should be 60 minutes. And needle means a thrombolytic. The two big thrombolytics we use in most countries around the world is either TPA, which is anectoplase, or now we're seeing a lot of TNK, which is connectoplase. The difference between the two is that TPA or anectoplase takes 2 doses. You have to bolus 10% of it and then give the other 90% of it over 60 minutes. That's double dosing. It's room for medical error. And believe it or not, that can take place. and it's dosed on mg per kg ideal body weight. Number two, TNK is one dose, one and done, which is really nice. All of us that deal with giving drugs always like that, one and done is so much fun. Rhymes even. So we are going to more TNK at Haywood and Athol than we are with TPA. And it runs about the same price, fortunately, so it's not more expensive as some drugs are. So that's the thrombolytic, and that's the time frame that we're looking at. What about the thrombus patient? So the patient goes to CT, we often get CT angiograms, and the angiogram is showing a big thrombus or blood clot in the left MCA. So the middle cerebral artery is all clotted off. The patient has right-sided symptoms. They're like this. Now, what am I going to do? I'm going to send this patient, transfer them to UMass. They're going to go straight to interventional radiology. They're going to stick a catheter up there to probably access either the carotid or the right artery, right radial artery, go up into the brain. They're going to actually evacuate the clot, put some thrombolytic in there or a small basket to go around it, divert the clot and open that circulation up and get rid of the stroke. Thrombectomies can take place anywhere from 6 hours to 24 hours after a stroke. Isn't that nice? So that's why it's okay to bring in an awake stroke. They went to bed at 10:30, they woke up at 8:30, and now they're stroke-like. So anytime in that time frame it could have happened, but we're still within a 24-hour window, right? So they may qualify for thrombosis. Thrombectomy. Okay, next slide. So this is how we treat them. They have to be treated within 3.5 to 4 hours. That's why it's really good. So even if you guys are outside the window, you pick up a stroke patient, if they're 6 hours from last time doing well, you call the stroke alert anyway. Just because you can let me decide that whether or not, because they're outside the window for a thrombolytic, right? But they're still in the window for thrombectomy. Okay, so this is really good to know. Next slide. Okay, I already told you about TPA. And connected place is TNK. That's the other. So it's either this one or this one, and we're going to TNK, more important. Now, Dan, what about fluids? Should I give fluids in the field? I'll leave it to your discretion. A little bit of fluid bolus doesn't hurt anyone, but very subtle. If the patient's hypotensive, I would suggest a fluid bolus. When in doubt, just call radio. I think fluid is really helpful, especially with these patients, because the extra fluid in the blood vessels may help down the road. So, Dan, do I control seizures if a seizure happens in the field? Hands down, yes. Are there any contraindications to using midazolam in a stroke patient that's having a seizure? Absolutely not. Is there any contraindication to giving dextrose to a patient with a stroke with hypoglycemia? Absolutely not. What about the patient that has a blood pressure of 210 and they're having a stroke? Should we treat that? Absolutely. Field treatment, probably med command, but usually we like to treat that in the ER under very close observation. We usually use labetalol and bring their blood pressure down gradually. If you bring the blood pressure down too quick, what happens upstairs? Cerebral edema. Yeah, you get swelling in the brain. Next thing you know, we're actually activating code. Not a good thing, and that in turn activates the legal system. So, next slide. So here's some pitfalls for us all to pay attention to. Number one, we don't identify the patient correctly. Are we perfect? Absolutely not. We are all humans. We all stumble once in a while. Don't beat yourself up because you missed diagnosing a stroke in the field. There's lots of stroke mimics out there, migraine, seizures, even hyperhysteria or a psych patient can fool you. An incomplete exam. If you guys are in a hurry and you're thinking you're XYZ instead of ABC starting, you may miss something. Okay? Always approach your patient in a very systematic way every time. Regardless of what the call is, I have to pinch myself each time to do that in the room. If I'm going in to see an abdominal pain, a chest pain, and unresponsive, I need to approach the patient in the same way every time. What are their vital signs? Are they responsive? Are they breathing? Are they circulating? Are they ventilating? the big life threats are out of the way. And I always think the worst and work backwards. So my chest pain patients is a dissection, an embolism, an MI, a ruptured chest, a tension pneumo, until proven otherwise. In office, you know, as well as I do, often you can rule those things out in a minute or two, right? You know, walkie talkie, I've had chest pain for a week. That's probably not an embolism or a dissection, right? Okay? Not considering the unusual. So I'm bringing in an African American with stroke-like symptoms. Could they be in sickle crisis and having a stroke? So think outside the window. We're getting more migrants now. So is this migrant from Sicily? Do they have beta thalassemia, which is a blood condition that makes it clot a little easier? Is this a person from Japan that has thalassemia? What's it called? Thalassemia minor? Just odd, weird stuff that you won't see very often. Okay? And don't forget, do pediatric patients stroke? Unfortunately, yes. Can an infant with a BSD have a stroke? Absolutely. It's nerve-wracking. One of the couples in my church just had a baby 3 weeks ago, I think it was, and they found out that little Nathan has a BSD. So, of course, they're all nervous about it. They're going to Boston. It'll be fixed. The baby's fine, but, you know, it's nerve-wracking nonetheless. Next slide. Okay, we can misdiagnose a cerebellar stroke. Cerebellar strokes are special critters because patients off balance. How many people in our town are off balance day or night? And you know why they're off balance? The number one reason is not stroke, but you know that fire water that they like to drink. Could it be drugs that are doing this? Could it be prescription medications that are doing it? Absolutely. So you got to think outside the box. Managing blood pressure too aggressive, and I'll talk about. Thanks. Oh, the best stroke to have is that good putt on the green. Yeah. Hopefully make par, maybe even a birdie putt though. Okay. Now I'll open the floor and the people out in virtual land. Does anybody have any questions? Is there something I didn't talk about? Hopefully this wasn't too long and too boring and puts everybody on the same page. Me too, because it was a review for stroke.
On the fast ED score, it's kind of general practice, not necessarily protocol. The fast ED score of 4 or higher has a high incidence of probability of an LVO that needs a thrombectomy. So a fast score of 4 or higher, general practice is to go straight to a place that can do that, which for us would be UMass. Is that what you recommend, or do you want us to see us go to that center at a lower score, or is 4 okay with you? I believe the score of 4 has somewhere between a 75 and 80% likelihood of an LVO.
That's right. Based on the literature, on the 4 or more is just what you say. That's about a 75% give or take. They're having a big one. Yeah.
So if we have a fast ED score of 4 or more, we can request
4 or
permission
more
to
should
go
go
straight to
tertiary
UMass.
center. Yeah. And you can always call med control and ask for bypass. Yeah.
Or we can use that.
Yeah. You could, I don't see it, I didn't see it hard and fast in the protocols.
It's under point of entry protocol, which is like
Oh, that's,
area to area,
yeah, I
different
didn't-
from the state.
the point of the POCs are in the background. Yeah, I know when, and in my catchment area, I would not fault you at all for going, even without MedCon, and just go and they tell me later we went. Because the outcomes are much better if the patients are seen quicker. Time is brain, just like time is heart. So, yeah. I think it's better to overshoot it than undershoot it.
On with too much oxygen can be bad for strokes. On that protocol is anything below 94% is oxygen still sticking with that.
Yeah.
Just-
So even if you get to the field in 92, put some oxygen on. Yeah. I don't know why 94 is selected. I think they have a lot of research. But
Yeah.
Yeah. As a normal human being, you and I are probably between 96 and 100 right now. You know, give or take. But yeah, 92 and less, especially since you're acutely ill.
Yeah.
Yeah. Good question. Anybody else? Yeah, it's some, in fact, one, I think maybe 2. maybe 2 or 3 of these are transports right to UMass with stroke-like symptoms, and they turned out to be other things, which is good for all of us, you know, but I'd rather all of this in this room err on the side of caution. What's the worst case scenario? A stroke with a bad outcome, or oops, it was a migraine. Just give me some Imitrex on the way to there. You know, obviously, the stroke is much more important because if we miss a stroke and grandma goes on to have a permanent disability, the grandchildren will be very upset with us, and we don't want that. But the bottom line is the patient. We all want our patients to do the very best we can, and if the patient ends up with a disability, it makes us all feel bad. Okay? No more questions? If you guys would like a 10-minute break, 10 minutes for tea